this area, Madison County, has been relatively sheltered from novel coronavirus infections up until recently. And the point of inflection was at the very beginning of September. And that correlates both with the start of BYU Idaho as well as public schools right around the same time. Both are culpable, among other things, in the sharp rate of increase of infection here. Empirically, we see a lot of new cases in 50 and 60-year-olds as well, especially in my area of practice. So it's not just college students. There are a number of cases in youth under the age 17 that are positive at this point. What I tend to see are the 50 and 60-year-olds, and we've seen a number of new cases in that age range. And some of them have been dreadfully ill. They've been hospitalized or had to come in for IV fluids because of dehydration and other issues. It really does reach across the entire spectrum. It's not just college students. That's absolutely a myth. And I don't think all of the blame can be placed on our local university, not a bit. There's been a lot of, a lackadaisical approach to wearing masks in this county. In particular, I've recently traveled. I was part of the test group for the Pfizer vaccine, so I had to fly to Phoenix twice in the last couple of months. Traveled through Salt Lake City, Phoenix. I didn't see anybody not wearing a mask in Phoenix that I can remember. I don't think I saw too many people in Salt Lake City not wearing a mask. It's different in this area. It's probably about 50-50, or maybe not even quite that, those numbers for people that will wear masks versus who won't. And so there's definitely a different approach to protecting oneself and one's families up here from what we see other places. I think most people are pretty reasonable when it comes to that, but the mask is not being mask rules are not being followed here as they've been dictated. So we're not doing well here at all with masks. There are several problems with that thought process. First of all, the herd immunity. Herd immunity as a term in medicine really applies to what happens after a population is vaccinated, not after they naturally acquire the illness. For example, herd immunity with measles, which is the most contagious thing we know of, is probably at around 95% of the population either has to have recently had it or been vaccinated against it. We don't know what the herd immunity numbers of coronavirus are. It's probably 60 to 70%. It's numbers I've seen bantered around. The problem is only 10% of the population at large has been exposed to coronavirus. And if you really think that herd immunity will occur naturally by people getting it, it will be at a tremendous cost in lives in this country and elsewhere. You figure that we have only seen 10% be exposed thus far. Multiply that out by 6 or 7, how many lives have been lost. And we've already hit about 3 times what the Vietnam War killed in this country. It's a big deal how many people have died. We can't afford to look for herd immunity. And the fact of the matter is it probably won't occur anyway because people need to be vaccinated to reach those numbers. If we rely on people getting coronavirus, it will take months before we can even get somewhere close to that, at which time people will probably be starting to get it again, as has already been reported as happening. So that's not a good practice or policy. That is not even remotely based in science. That's Facebook mythology, is what that is. Comparing the danger and severity of influenza to coronavirus, novel coronavirus, is probably not a good comparison. For one, we can effectively immunize large populations very cheaply, very quickly against influenza, so they really don't stand up to each other. Second of all, influenza tends to be less of a random number generator when it comes to whose lives it will claim versus those lives who it won't claim. We kind of know who's going to get dreadfully ill. Coronavirus is absolutely randomized in who gets sick and who gets dreadfully sick and who dies from it versus who doesn't. I mean, it's not only empiric evidence, it's also rational evidence that suggests that. In the last week, I've called a 96-year-old with his positive coronavirus test. He was cleaning out drawers in his house and he was feeling okay. I've also lost a friend of mine from high school. I'm 44, she's 44. She won't be around for Christmas with her kids. So it is completely unpredictable and probably not a good comparison to make. For one thing, it's a lot more virulent than influenza has been. People question the efficacy of face masks, and there's a number of reasons that people don't like wearing it. I don't like wearing it. I hate it. I wear it for 9 hours a day. I wear it on Sunday. I wear it on Saturday if I'm going to the hardware store out with my wife. So I think we can all collectively say that we hate it. I don't think there are people that like it. So now that we're past that point, now that we all know that we hate it, why do we wear it? Well, we know that face masks, including these very thin masks that we wear in healthcare settings and even cloth masks, will catch some, if not a lot, of the spit that comes out of our mouths. Spit is the Greyhound bus on which coronavirus travels. And it absolutely is imperative that we capture spit. They've done studies, they've shown these wonderful videos as far as teaching how the stuff is spread is concerned on NewEnglandJournalMedicine.com that I was looking at today. And these are called, I think it's Sheeran photos, where they actually can use, I believe it's ultrasound, to show what comes out of your mouth when you cough or sneeze. It's droplets, it's not individual viral particles. And the droplets are what are captured by the mask. My mask plus your mask equals pretty good, albeit not perfect, protection. What little bit of risk is still there is probably muted a little bit by the fact that if, heaven forbid, you're in a room with somebody with coronavirus, they have a mask, you have a mask, you receive a smaller inoculum, there's good evidence that shows that patients with that will have a less severe case, even a subclinical case of COVID, versus somebody who has a larger inoculum at the same time. And this is something that's been well documented for hundreds of years. The term is variolation, which relates back to variola, which is also known as smallpox. Back in the 1700s, they would take a smallpox pustule from somebody that had smallpox and they would scratch it, and then they would scratch the skin of somebody who didn't have smallpox, hoping to give them a smaller inoculum, allowing that person to have more time to build a more effective response. Well, that's what masking probably does. That's a rough shot explanation of it too, but we know that the inoculum will determine how sick somebody gets. Where we're at right now, specifically at Madison County, is we're critical mass, and our trajectory is dreadful. I guess the rate of change has been so dramatic in these last few weeks that if things aren't going to change, pretty soon we will be at full capacity, not only at this hospital, but our medical systems in general to take care of patients. A number of our patients may not be hospitalized all the time, but they need to come in for fluids or other treatments. During the day, we have a capacity for what we can take care of patients with that as well. And the biggest concern we have here is that the trajectory of our positives in this county is so sharply angled up that if things continue at this point, we'll run out of capacity, a matter of days or weeks. It's finite. We don't have a limitless supply of beds or staff. At a certain point, we have to take care of the people that are sickest the first. That's what we do here, what we would do anywhere. And if we reach a certain critical mass, either with staffing or with beds available, we're going to start being able to, or being unable rather, to take care of those that are coming in for semi-elective surgeries. If somebody needs a total hip, they need it now. They don't need it 3 years from now. And to be put on a waiting list for something like this is really going to affect how we take care of people at this hospital. So we can't afford to reach critical mass. We're not there now. We'd like to avoid that point. But some of the hospitals in the area are reaching that point or have already reached that who's to say that we won't be there very quickly here? Where we're at with the vaccine trials right now, so Pfizer, their vaccine is the lead horse right now. They have already administered all of the vaccines or placebos, so everybody has had their shots. So essentially the trial is closed now and they're waiting for data. There are two arms. There's an arm that is a placebo arm and there's an arm that's a treatment arm. Roughly 22,000 in both arms. So this is a big trial. This is larger than Rexburg, amount of people that have been enrolled in this. It's not a small trial at all. Right now they're waiting for a number of people in the placebo arm to have COVID so that they can compare numbers in that arm against the number that has received the vaccine. By doing so, they can see if the vaccine is effective or not. There's already very good empirical evidence that the vaccine is safe. In other words, we haven't seen a lot of problems with side effects and things. The usual side effects that you would expect with tetanus shots are what we're seeing right now. And so we feel very good that the safety is good. What we need to see is how effective it is. It doesn't have to be perfect, it just has to be pretty good. The data will probably be reported sometime between Halloween and the end of November. They'll probably have all the data they need by the end of October, but they want to give a little bit longer in the treatment arm to make sure that people aren't truly getting sick or developing problems with the treatment. So things are delayed a little bit that way, but probably by the end of November then we'll have the data. If that data is ideal, if it looks favorable, then very quickly these vaccines can be produced. They're easy to make, they're fully synthetic. They're what are called mRNA vaccines. And if anybody wants to know what an mRNA vaccine is, there's a wonderful explanation at nationalgeographic.com that is probably better than anything else that I've looked at. It's where I send my patients to go read about it. The data are also reported heavily in New England Journal of Medicine. They are not reported on Facebook. They are not reported in tweets, and they're not reported in other little cute blurbs online. So you really have to review the data. It's out there. It's free for anybody who wants to look at it right now. I think most people with some science background, college degree, even high school science background can understand this stuff. It's not that hard to grasp, I think. And data are there to review. It's wonderful, but it's very hopeful that we'll have this stuff available, these vaccines, by hopefully sometime in December. They can quickly produce this, and once it's made available to the public, you will see very quickly a collapse. Once a number of people have had it administered to them, you'll see almost a complete collapse of the transmission of coronavirus. And so I think the important thing is for people to know that the end is very close. We don't have to wear these masks forever. It's not a hopeless, endless tirade that we're on telling people to wear masks. Once somebody has COVID and they make a full recovery, what I've heard, and I've seen it a few different websites and journals, is that they're probably felt to be somewhat resistant or protected for about 3 months. We don't know if it lasts much longer than that. There are two types of immunity. There are antibodies, which is what's called humoral immunity, and then there's cellular immunity. We can measure antibodies. We can measure humoral immunity. We have an idea of how well somebody is protected. For example, we know that patients in these early trials of vaccines, that they have 4 times as many antibodies compared to somebody who just recently convalesced, who just barely got over COVID. That's great news. It's harder to measure the cellular immunity, which involves memory cells and killer T cells and things like that. That's not easily measured in lab studies. It's not cheaply done. So we don't know exactly how long that type of immunity lasts, but it is felt that the antibodies, the humoral immunity after somebody has coronavirus, does wane over time. And so it's probably not a permanent immunity, which suggests that probably as we go through this, that a coronavirus vaccine will likely be needed as a booster on a regular basis. But that's not a bad thing necessarily. We boost our immunity every year against influenza, different strains of influenza with a flu vaccine. And it's not unreasonable to assume that we'll need to do that going forward with coronavirus. We're really not doing a good job here. If you look at the data on the state of Idaho's website of coronavirus cases, there's a separate type of graph for Madison County. The y-axis has to be many times higher than everybody else's axis because we have so many cases, and the trajectory goes up like a rocket launch. It doesn't inflect at the top, it's still going up. And what that suggests is it's not just university students, it's not just kids from school, it's everybody is passing it. My evidence, and what I've seen, rational evidence from my clinic as an internist, is that 50 and 60-year-olds are getting this right and left. They're probably getting it from their families, although they may be getting it from being cavalier in the stores. The problem I see with coronavirus, and I think it's important to note this, is that it's not just do you live or die. You can't just look at those as being the only two endposts here of this field, because if you're just looking at mortality statistics, I like my odds. I wouldn't worry about it. I wouldn't wear a mask either because I am statistically unlikely to die from this. But there's a sizable number of people in the middle of those two goalposts that will have long-term heart damage. We know this from studies. We also know that people are wiped out for a couple of months after this, and that's probably because the lymphocytes, as part of the body's immune response, are infiltrating both the heart muscle and the lung tissue, and that does not quickly resolve. We know this from other viral infections, that people will develop long-term heart dysfunction. It may not be permanent, but it's enough to stop somebody from walking 100 yards or taking a flight of stairs that otherwise was able to do that.